Welcome everyone to the latest in a series of discussions around shifting the burden, co-sponsored by ASPA and the Bedrosian Center at the Price School at USC. My name is Raphael Bostic. I'm a professor at the Schultz Price School and the Bedrosian Chair and the director of the Bedrosian Center for Governance at USC. I'd like to welcome you all to this event. It is very good to see everyone, and it's a pleasure to be able to stand here. So this is the first time, I think this may be the first time in public I've been doing this, so thank you for giving me an opportunity to debut with you guys. It's great to see you. The Bedrosian Center is a center that is really focused on the doing of policy as opposed to the design of policy, and is trying to lift up issues and concerns about how we can better implement policy and improve the delivery of services and the capacity of the institutions that deliver that policy. As part of that, we like to engage the public and the practitioner community in issues and topics that really speak to those things, lifting up some best practices, highlighting challenges that might exist, and trying to give everyone some food for thought as they go off and do their work as to how we might all do better and make sure that the good ideas get done more and the less good ideas get done less. So this is part of that, and before we get into the program, I'd like to invite Paul Hubler to come up. He is the director of the Southern California chapter of ASPA to offer a few remarks. Paul?
It's got it had an umlaut on it. Thank you, Raphael. It's really a pleasure to gather once again for what is the second in this series that we, ASPA, initiated with the USC Price Bedrosian Center on shifting the burden, which looks at really the trend, we feel it's a trend of shifting the burden, not only the fiscal but service provision and delivery burden from and amongst state, federal, and local levels of government. I think in some cases the shifting the burden is a more ominous undertaking. The recent dissolution of redevelopment in the state of California, I think, was one that was obviously vigorously contested by the localities, and they remain very unhappy with it today. We started this series looking at shifting the burden on the provision of law enforcement services, of the state shifting some prisoners from state prisons to local prisons, and other aspects really of this trend. That was in the first of our series. I think this one is going to be a happier shifting of a burden and responsibilities and service deliveries. I think it's, from what I've gathered, far more cooperative, at least in California, undertaking to really try to revolutionize, I think, the provision of health care nationally and in the state and in our county. I wanted to just mention, this is obviously part of this series. We've done other panel discussions as well, one on the Bell scandal and proposed legislative reforms on state and local pension reform and fiscal sustainability leadership in Southern California. So we're going to continue to work with USC and the Bedrosian Center on these types of panel discussions. We hope you'll find them interesting and helpful as you try to get a grasp on the public administration and what we're really faced with as public administrators or future public administrators today. ASPA also organizes student professional dinners, and I would encourage the students here to attend. We just had one last week at the University of La Verne out in eastern LA County. It was very successful. We had 3 either current or former city managers talking to the students. It's an informal setting. Ask them whatever you'd like. They'll tell a lot of war stories. I think it's a good way to get an insight into leadership and public administration. Our next student professional dinner will be held at the home of Bud and Denise Overham in Burbank on October 22nd. So check our the ASPA website, or send us an email for more details about that. I did want to recognize I have several board members in attendance today. If I would just ask if they could stand and be recognized. Lucine, Veronica, and Christy's already standing in the back taking pictures. They're really we're an all-volunteer organization, and they've really kept this program going and our chapter going with lots of events. And in particular, Veronica really did yeoman's work in pulling together today's panel. And finally, I'd like to thank our panelists in advance and our partners at USC, Raphael Bostic, Yan Tang, Aubrey Hicks, and Dan Mesmanian. They've really made this process not only interesting, but actually a lot of fun. It's good to work with folks who are so committed to developing a better understanding of public administration in Southern California. With that, I'll turn it back to Raphael. Thank you very much for joining us today.
Thank you, Paul, for your kind words, and thank you and the organization for your partnership. This is really an important thing for us, and I really view ASPA as a vehicle for having these conversations and actually ultimately changing and improving how things get done. So thank you very much. It's good to see you. And thank you for your thanks to everyone else, because I was going to do that, but ditto what he said. The committee that worked on this was great, and really has put together a super group of speakers who I will now turn the program over to. Just wanted to give a few perspectives to help you set a context for the conversation. You know, the notion of shifting the burden really explicitly acknowledges that there are obligations and commitments that are done at all levels of government. That's the federal, the state, and the local level of government. So as we've tried to put this panel together, we thought it would be important to have perspectives from all of those levels and to talk about how the world and the environment is viewed from that perspective, but also how it interacts and intersects. And so we have a great panel of federal, state, and local folks. The moderator for this panel is a friend of mine, one of my favorite faculty members at the Price School and an expert on this subject, Dr. Bob Myrtle. He is the director of our Executive Master in Leadership program and a pillar in the school and in the university on issues around healthcare management, around management and leadership. I could think of no one better to do this moderation than Bob. So thank you for agreeing to do this. It's great to have you with us. As panelists, we are extremely honored to have all of our panelists. We are particularly grateful for Senator Ed Hernandez. He's a state senator, spends a lot of time in Sacramento. We are always grateful to have you down back close to the district and to talk about these things. Senator Hernandez is the chairman of the Senate Health Committee, and so he has been thinking about this probably more than anybody else in the state, and to some extent, and will definitely be able to offer some key insights. At the federal level, we are very pleased that Herb Schultz agreed to speak and join us. He is the regional director of the U.S. Department of Health and Human Services for Region 9. So he's over everything that happens in this area around healthcare and the provision of health services. And we are just so grateful that you made some time for us, so thank you for being here. And at the local level, we have two speakers, two panelists. The first is Stephanie Hall. She is an alum of the program at Price, so she spent a lot of time in Lewis Hall. Welcome back home. It's good to have you with us. She is now the Chief Medical Officer and Associate Dean of Clinical Affairs at LA County and USC Medical Center. So she oversees almost all the operations that go on there, is intensely aware, and this touches her every day. And then the fourth panelist we have is Robin Kay, who is the Chief Deputy Director of the Los Angeles County Department of Mental Health. When we think of healthcare services, there's also, in addition to physical health, the mental side, which can often present some significant challenges. And we want to make sure that as we have this conversation, it happens in as broad a scope as possible, so we bring in all those perspectives. So thank you all for joining us. And with that, I will turn the panel over to Bob. Bob?
Thanks, Raphael. we've agreed as a panel we're going to sit and not use the podium because we want to get some questions and answers going and make a real interactive dialogue. Well, I thought before we got started, I'd ask Herb kind of to give us a synopsis. I suspect there are a number of people here that are really familiar with the Patient Protection and Affordable Care Act. And I suspect there are some people here that are really not clear what it's about. So I thought I'd ask Herb to kind of give an overview, a framing of this. I've heard him do this in the past, and it was a marvelous education. It was really enjoyable. And then I thought I'd go to Ed because the state of California has been struggling for many, many years how to come up with a health delivery system that could work for everybody. And I'd like to get kind of his thinking on how this tied into a number of the initiatives that have gone on at the state level, and then go to Stephanie and Robin and get some reactions. I have a series of nasty questions to get us going, but I'd allow at least them to get their thoughts on the table. So, Herb?
Okay. Thank you. I really appreciate being here. I was actually with USC last week. It seems like a while ago, but it was at the Athenian Society. And I also appreciate the fact that I'm surrounded by doctors between Dr. Bostic that's there, and all of you are either ODs, PhDs, or MDs, whatever, so thank you. My mother always wanted me to be a doctor.
We can still work on that.
And that's why there's therapy on Sundays. Anyway. So I'm nothing if I'm not blunt. What I thought I would do, and I appreciate it very much, is Veronica sitting out there first? Veronica, stand up, because she's the person that put this whole thing together on behalf of the panelists, and I think ASPA as well, but you had a really great attack dog, and she just made sure that we had everything we needed every day. So thank you very, very much, Veronica.
I'm not sure attack dog is politically correct.
Yeah, no. Yes, I just got said that was not a politically correct term. My apologies. Let me start out this way because we had a series of questions and I think it sort of fits into that. Department of Health and Human Services, U.S. Department of Health and Human Services, one of three federal agencies, the other being the Department of Labor, and the other being the U.S. Department of Treasury, and very specifically, in a lot of ways, the Internal Revenue Service, really have, it's sort of a troika of the main implementation pieces of the Affordable Care Act. And I think you started this conversation out really well in laying out this, because what I've been known to say is that this law is historic, this law is a federal framework, and there is much work that we have begun to do, and indeed, in fact, have done. A significant percentage of the federal regulations, if you will, the regulations that really guide the implementation for states and local government, and in my regions, tribal and territorial governments, because I have the Pacific territories and 3 countries we have public health relationships with. But the important thing is that the ultimate success of this law is going to be because of the coordination and the effort, not just between federal, state, local, tribal, territorial, but also because of community members, whether they are doctors, hospitals, nurses, whether they're small, medium, large businesses, community-based organizations, union officials, health plans. In other words, you as stakeholders, academics, philanthropic organizations, it's going to happen at the state and local level. And Dr. Hernandez will talk about, Senator Hernandez will talk about which of the, if you will, implementing regulations at the state level have already been put into motion. But from the federal government level, we're out there every day trying to work with the community, because the Department of Health and Human Services really has the significant part of making sure that when I talk in a second about the 3 stools, the 3 legs of the Affordable Care Act, we have a very strong role in ensuring that the framework is set up, that it's consistent with what Congress wanted, but also we're working in coordination at this level with the state and local level. And when I talk about that, I mean everyone from the senators in Congress to the governor and the state legislature and to his administration, but also to LA County and other counties in the state, and in some cities, only 2, city health departments, Pasadena and Long Beach. So there are a lot of work that actually, most work gets done through the county. So think about it that way, but this is really the time, because these decisions are being made now, not just made at the federal level, but are being made at the state and local level. And therefore, what my job is threefold, and then I'll talk about the 3 stools and turn it over. My job is to do 3 things with my office, is yes, to oversee the entire Department of Health and Human Services, but I'm not the regulator, okay? I'm not the Centers for Medicare and Medicaid Services. They're regional administrators on my management council. I make sure that the policies of the president and of the secretary do get implemented through our various divisions, federal, state, local, tribal, territorial, with input from the community. So what does that mean? So role number 1, outreach and education, whether it's the ACA or another big issue that we deal with in this department, and this department of 22 agencies and offices. But also, I spend a significant amount of my time, what I think many of you are involved in or trying to be involved in, and that's setting policy tables, policy development, because this president, this secretary believes that we're not going to be successful in the implementation of this law if we're not working with not only those government officials, but with the community. And so if we're proposing something, or even if we're not, but you have views about, well, this is a part of the law that we have this particular view because I'm a small business person and I'm concerned about, you know, how this new marketplace called a healthcare exchange is going to operate. I'm setting those policy tables to make sure that 24/7 we are grounding the policy implementation at all levels of government in reality. And I get to bring the policy, not only development, but I get to advocate as a member of the Secretary's senior team in doing that, and as a presidential appointee, I get to do that every day, and I can only do that with doing you. And then the third part is what I call regulatory implementation. It really is troubleshooting. It's troubleshooting between governments, it's troubleshooting between organizations that deal with similar issues, and sometimes it's just doing introductions, if you will, to people in the community that need to talk with the state, for example, about implementation. It's not the federal piece, it's the state piece. So if you look at all of this overall, 3 main legs to the Affordable Care Act. 1 is increasing access to coverage and expanding health care coverage. That's stool 1. So increasing access to coverage, expanding coverage up to 30 million people by January 1, 2014, and that will take place in the private sector as well as a significant expansion of the Medi-Cal population in the state. And we could talk about how it's done on the private side and public side and where those burdens may or may not be shifting. But that is a state-based private sector expansion. That is obviously state and local working with the feds when you talk about Medi-Cal, federal dollars shared with state dollars, and a joint program. Second is consumer protections. Many people have focused on the fact that the law has a January 1, 2014 effective date. I think what more and more Americans are waking up to, historic provisions, is consumer protections. So when you hear about 19 to 25-year-olds, young adults, how many of you are under 26? You can leave now. 19 to 25-year-olds. You know, it's 3.1 million young adults on their parents' policies now, but that is 435,000 in California. And, well, what does that mean? Those are 3.1 million newly insured. That's not the number of people that had other insurance and switched over. The number of others that had it is about 3 million. But that's 3.1 million new insured in a year and a half as a part of this expansion of healthcare. For seniors and people with disabilities who have high drug costs and multiple chronic conditions, there have been 5.5 million seniors and people with disabilities have had $4.5 billion worth of discounts on their prescription drugs so that they don't have to choose between food and their prescription drugs. And I've been a person living with HIV for 21 years, so when I talk about and do the work around ensuring that no one with a pre-existing condition, in this country it's now illegal to deny children health care under 19 because of a pre-existing condition, and we have a bridge program to get us to January 1, where no one, adult, child, not only can't be denied, the product that they buy, the premium, cannot be priced on the fact that they have or have had a pre-existing condition. Many of those consumer protections went into place in the first 6 months of this law. And so when we talk about implementation, we talk about that. And then the third stool is increasing quality and containing costs. Many people think that you can't do both at the same time. And in effect, we actually are. And there are programs that we are doing. It's looking at, sometimes it's the more technical, but it's the delivery system. How is healthcare delivered? How are hospitals and physicians and nursing facilities and others trying to, if you will, encourage the coordination and integration of healthcare? And for us, in the Medicare world, in the Medi-Cal world, California has been a real leader, and a lot of the ACA and a lot of our programs in the ACA that we're implementing are based on that. But for example, hospitals starting yesterday are getting graded on whether or not they have an appropriate level of readmissions to the hospital within 30 days. And for those that are below the average, they're going to get dinged up to 1%. For those above, they're going to share $850 million in this fiscal year because their quality is higher. And so we can talk about a lot of other parts of that delivery system reform, but there's a $10 billion innovation fund. We've always said, well, what can we do? There's all these demonstrations. There's now the ability to not only be creative on how you're paying providers and how the care is delivered, but the secretary actually on the main program around trying to get coordinated and integrated care, called an accountable care organization, she can actually expand it without going back to Congress. That is a huge historic shift when you think about how many demonstrations are done, and then people say, well, whatever happened with that demonstration? So number one, increasing access, expanding coverage to 30 million Americans. 2, consumer protections, which have gone in place to, if you will, eliminate some of the worst abuses of the prior system. And then 3, increasing quality and ensuring the delivery of care is integrated and coordinated. Thank you.
It's a really complex piece of legislation, and Herb did a marvelous job of kind of laying out the major elements of it. And California's been thinking about this for many years, and you alluded to it, Herb. And so it's really great to have Senator Hernandez, who not only is chairing the Senate Health Committee, but also joins us as a practitioner who's living in that community. And so he's not a novice in terms of understanding public policy and what the state has been trying to do as innovators and leaders. So it's kind of nice that we have a chance to really, really be one of the states that people can look to and admire and say, California did it right. Ed?
Well, good afternoon, and thank you very much for allowing me the opportunity to spend some time with you and to kind of share what California is doing, but more importantly, the implementation of the Affordable Care Act. But I should actually say the implementation of the absolute most historical piece of healthcare legislation that this country has seen since the mid-'60s, since the Johnson administration, when we implemented Medicare and Medicaid. As you know, the country has always tried to move in this direction, obviously through the Clinton administration. The state of California always has been the leader, whether it's in the environment or transportation or air quality, but also in healthcare. And as you know, in 2006 or shortly after that, in 2007, we had AB 8 with the Speaker's bill. Governor Schwarzenegger wanted to move it forward, but unfortunately the politics and the dynamics of the state at that time didn't allow California to move forward with some type of universal form of coverage. I was involved with a debate at the time And the most difficult thing that we had to deal with in the legislature, even though California wanted to move forward, was the funding mechanism. You know, there's ways to make it work in the private sector, but if we were to increase access to the most neediest, we needed that federal dollar. Well, as you know, in 2010, President Obama signed, as I said, the most historical piece of healthcare legislation. So that is going to move us forward in significant, in large steps. But as you know, there was also another major incident that occurred. And as you know, it was challenged by the Supreme Court. And when the Supreme Court ruled that it was constitutional, that the mandate was a tax, and I think the only thing that I was disappointed is that the Supreme Court did say that each individual state had the option of opting in or opting out and weren't mandated to take the federal money for the Medicaid subsidies. Well, and I think that could be a potential problem for the rest of the country, definitely not here in the state of California, because California is going to utilize every single federal dollar to make sure that that happens. Well, you know, I'm very fortunate to be in a very unique position to be chair of the Senate Health Committee and to watch this piece of legislation unfold, but more importantly, to be part of all the legislation to get prepared for it. Give you an example, California is the first state to have an exchange, which is going to make it imperative and very important because California is continuing to take a lead role in that perspective. The governor just signed one of my bills, which is going to determine what the essential health benefit is. That's the floor. As you know, the federal government was determining that there was going to be 10 essential benefits. Then they made a ruling, or they recommended that each state determine what that plan is, so the governor signed it. We have several bills that have moved forward. Assemblymember Manning, the small group plan. However, I will say I'm a little disappointed. As you know, the governor did veto the market reform bill, but in his veto message, he did say that he had some concerns with the tiebacks to the federal government. And as you know, the state of California will be holding a special session in January to address all of the federal regulations to make sure we're ready and to implement the Affordable Care Act. We have the exchange up and running. We will be addressing, and I did get a call from Secretary Dooley a couple nights ago just to reassure me that the governor is committed to making sure that we get the market reform bill in special session on his desk and signed, because those are all the provisions that Mr. Schultz was talking about with regard to consumer protection. You know, guarantee issue, community rating, pre-existing, you can't get denied for pre-existing conditions. All of those are what's going to be in the market reform bill that we need to make sure we get done in January. The other thing that I will be bringing back in making sure that we get is what's called the basic health plan, because as you know, the exchange is going to be successful. Those who have jobs, the individuals, as we look at the Medicaid expansion up to 133% of poverty level, will be covered at no cost. But the segment of the population that I believe we need to address is the working poor. And those are individuals between 133 to 200% of poverty level that it's expected that they can be charged up to 10% of their annual income, and they're going to have a tough time choosing between health care and even just buying food. So the basic health plan will be able to address that, to be able to provide a much lower out-of-pocket expense and a much more robust product for them. But saying that, you know, obviously we are, as humans, are creatures of habit. And I think the biggest concern that there is the fear of the unknown and the fear of change. There's a historic opportunity in front of us, but every time I speak in front of groups, whether it's consumer groups, provider groups, constituency groups, there's always that concern of how this is going to be implemented. How is it going to affect them as providers? How is it going to affect the plans? How is it going to affect the consumer? What is the cost going to be? We have to take advantage of this and continue to move forward to make sure that we implement it. And yes, I agree, there are going to be a lot of hurdles. We definitely need to move forward. But I also need to take some opportunity to talk about some concerns that I have, because we are going to have some big challenges that need to be addressed. And some of the challenges that I believe that need to be addressed is we have a huge capacity problem and a workforce issue. Because if you look right now, the system that we have set up, the individuals that are uninsured or underinsured are not utilizing the healthcare system appropriately right now. The uninsured or the working poor wait to the absolute last minute to seek care. And when they do, it's usually the most expensive care, and it's usually through the emergency room. Well, pretty soon, we're going to be mandating that every single person in this country and the state have health insurance. Well, let's say they get a health insurance card. What good is it to have health insurance if those same individuals don't have access to providers? And we have a huge disparity of where we have providers, but more importantly, the distribution of those providers. And we have it in predominantly two communities. We have it in the rural community, and we also have a huge workforce shortage and disparity problem in the communities of color, the communities which are predominantly Latino and African American, and unfortunately the communities that seem to have the highest incidences of chronic disease where the care is needed the most. So if we're really going to solve this problem, we have to not only look at the implementation of the Affordable Care Act, but we also have to look at providing the access to these providers and, more importantly, address the capacity of it. And again, I couldn't agree with Mr. Schultz more that increasing quality, but also decreasing costs. So these are all the issues that are facing us in the state of California. I've been running a series of committee hearings to look at the access and the workforce. We are strategically moving forward, obviously, with the implementation, and California will continue to take a leadership role. But the more important thing is to make sure that we have access to these patients and obviously increase in our quality as well as decrease in our healthcare costs. And then one final point, what I'd like to just mention before I close, and obviously allow the other panel members to discuss, to have their points given to you this afternoon, is in the healthcare arena and as health providers with all the uncertainty that is out there, what we need to do is we need to fundamentally shift the way we see patients. Because if you look at how we currently treat patients, we have a tendency to treat on disease and disease management, and providers have an incentive to bill based on provider codes and ICD codes. What we have to do is we have to look at finding mechanisms to make it so that providers give them an incentive to keep people healthy and reduce healthcare costs that way. And I think this is where the uncertainty comes in with regard to the provider world, because at the end of the day, we're going to be forced and we're going to be needing to see more patients at a lower expense and be more efficient. And obviously that's where, you know, we look at the ACO models, the integrated models, where we look at you know, everything from electronic medical records, how we're going to do e-prescribe, how we do with Cal eConnect, and how we do the portals to allow us to be able to get information to other providers, how we look at, you know, dealing with internet and technology. But with that, I'd like to just close by thanking you for allowing me to spend some time with you, and also just in full disclosure, and I need everyone in this room to know and understand, even though we're here in USC, my youngest daughter is a graduate and is currently a graduate student in UCLA, so you have a Bruin fan here in the house. So whatever you do, do not hold that against me. Anyway, thank you very much.
Well, when I was listening to both Ed and Herb talk, you know, the County of Los Angeles, so our microcosm is kind of a unique laboratory because it really replicates all of California. We have urban areas, we have desert areas, we have an island across the way, so we're almost like another country. We have our own coastlines to look after. And this issue of providing care for Medicaid or Medi-Cal in California and the uninsured and in areas of, where we really don't have the resources is something that the county has been struggling with many, many years. And this is really an opportunity to try to pull together, I think, some of the challenges that we've faced in the county, and that's really integrating behavioral health with physical health, and also tying it into public health. So I might ask, I'll start with Stephanie, but then I'll go to Robin. What's keeping you awake at night when you think about the Affordable Care Act?
Lots of things. But first, I'd like to say just a few words. I'm the Chief Medical Officer at LA County USC, and I work with the Department of Health Services, who's responsible for providing care throughout the County of Los Angeles. And our mission really is the safety net system for the County of Los Angeles. And what we do is provide services to those patients, you know, that others may not be willing or prepared to provide services. And the words that Senator Hernandez spoke about are very close to me, as my background is in training as emergency medicine. And I've staffed emergency departments throughout the Southland. And it is true that patients wait when they don't have resources to the very last minute for things that can be prevented. So the Department of Health Services and my facility in particular is anticipating the implementation and the expansion of healthcare resources, as Senator mentioned, primarily the expansions of Medicaid. Our job and our mission and our strategic plan going forward from here until January 2014 and on is to address those issues. Number one, access to care, to improve access to all patients who require services by really redesigning all of our health clinics, our hospitals, and the way we deliver care. The second thing is, in so doing, is to collaborate with our community partners. So the area that we anticipate the biggest challenge is that when people do become eligible, and we're expecting about 3 to 3.5 million people become eligible for Medi-Cal, that they will then have an opportunity to choose, and where do they want to go for their health care. And in the same way that Massachusetts experienced when they expanded services and care, is that, well, now they have coverage, but where are the providers? And so what we want to do is to make sure that we are situated to provide the maximum amount of health care for the most effective cost. And so by partnering not only with our community partners, but also looking at the way we do business. And the first area of our focus is primary care. Providing good quality primary care in a preventive way prevents people from their diseases advancing to the point they need to be in the hospital. The last place that we want patients is in the hospital. That's the most expensive and is the biggest drain on healthcare dollar. So our focus is expanding our primary care, providing access, that it's easy, and it's also patient-centered, because one of the things that has plagued our system for a long time is the patient experience. And a lot of study has gone into public hospitals and have shown that, in fact, our quality metrics are equivalent, or in some cases better, than private facilities. So it's not about, at least in our county, it's not necessarily about quality, it's about the patient experience. People wait too long, the style of care may not be centered on the patients. So our focus is, again, is to really look at how we're going to provide the primary care services in all of our health centers. There's a reorganization that has just undergone, that the health centers now are integrated and are organized under an ambulatory care model. And so that is being led by Alex Lee in the Department of Health Services. At the hospital, and where my focus is, it really is then, once the primary care is situated, then where is specialty care going to be provided? And this is for issues of referral. And so some unique and innovative things that Senator Hernandez mentioned is, how can we provide additional access to, for example, specialty consultation when there aren't enough specialists? When there's only one specialist in a whole county for a particular disease, then how do you maximize the use of that specialist? And the first thing that we've implemented is a program called eConsult. And this is where our primary care providers in the community, not necessarily just a county facility, but a community provider, as well as our county providers, can log on to a program and ask for a consultation online with a specialist. And so far, our implementation has showed that 44% of the time, a face-to-face follow-up in-person consultation with the patient is not necessary. That essentially then gives us the opportunity to save those clinic appointments for those people who really need the care. And it eliminates unnecessary or redundant, duplicative visits, so it maximizes the use of our healthcare dollar. Other things that we're working on is, in the specialty care, is every clinic is undergoing an intensive evaluation of our productivity and identifying, are we as productive as we should be? If every clinic has a certain number of providers, how many patients should we be seeing per hour, and how many patients should we provide services to at the end of the day? And one of the challenges that our director has put forth is that by the end of this year, his expectation is that we increase our productivity to provide services not only in the primary care sector, but in the specialty care by 10% without added resources. And we are already achieving that. Currently, our facility is measured at, we've already increased our productivity by clinic by 7%. So we're very close to reaching that 10%, and I hope that our, by the end of the year that we will not only meet the 10%, but exceed it. Other areas that the department is working on is, I mentioned the patient experience, and really working to make patients feel welcome, to have the ability to communicate with their physicians through electronic portals. And so in order to achieve this, the Department of Health Services is investing in a $245 million electronic health record that will integrate all health records for our patients throughout the County of Los Angeles. Currently, each facility has their own system. They don't talk to each other. As a result, there's a lot of duplication, loss of information, a very inefficient way to do business. And so we hope within the next 3 years to have a system in place that will allow patients move from one area of the county to another without the loss of their patient information. So this will be a huge improvement in the opportunity and reduce costs and improve the quality of care. So I think that kind of summarizes the points that I wanted to make, and so I hope I answered your question, Bob. And
Good job, Stephanie. Thank you very much. So I'll ask Robin the same question that I asked Stephanie, and that's what's keeping you awake at night?
Well, maybe a better question would be what's not keeping me awake at night.
Okay.
You know, I want to just comment on two areas that were brought up by all three of my fellow panel members. And before I do that, I just want to say thank you. This is a rare and special honor, I think, for the Department of Mental Health to be on a panel with federal, state, and also my DHS partner. Too often in our history, behavioral health, mental health, and substance abuse have been considered as sort of separate and apart from health services. And so I think the significance of having DMH, the Department of Mental Health, and Mental Health Services, Behavioral Health Services, represented on this panel is something that's worthy of note. And I want to thank you for the honor of being here. Just a word of background. In California, mental health services have been delivered, public sector mental health services have been delivered through a carved out system of care. The counties deliver what are referred to as specialty mental health services, and those are services for people with the highest level of mental health needs, people that meet medical necessity criteria as defined by the federal government and is applied in the state. And so over the last more than a decade, through a special waiver, in California and in Los Angeles, we have evolved a system of care based on a movement called the recovery movement for people with serious and persistent mental illness. And that's enabled us to develop the kinds of non-traditional mental health services that we know are successful and very much needed by our clients. The challenge for us as we move into the ACA 2014 and beyond is to ensure that we can carry forward those experiences with our clients and family members that enable them to be successful, to have more than just a diagnosis or an illness, but actually to embrace recovery and have a full life as we move forward with cost containment and changes in service delivery models. So we're, like everyone else, concerned about increasing capacity and ensuring access to care. We've been fortunate that so far the 1115 waiver and the low-income health plan, as it's operated, as it's rolled out in California and in Los Angeles, has allowed us to get sort of a jump start on 2014. We have increased the capacity in Los Angeles, bringing in new providers delivering services, mental health services, in new ways. So we have begun increasing our service delivery network, traditionally sort of underfunded, although LA County, it's hard to say that, but LA County operates not only the directly operated system of mental health care, but we also contract with more than 123 legal entities. I see two of our partners here, Wendy Wang from Pacific Clinics and Jack Barber from Barber and Floyd and Sharp, delivering those specialty mental health services in the community. But we've begun over the last year contracting with medical providers, health clinics, that have the capacity to deliver specialty mental health services in integrated health and mental health settings. We're also working intensively on expanding, as Senator Hernandez referenced, expanding both the number and the kinds of providers that can deliver specialty mental health services. One of the concerns that we have, and I think you mentioned it, Senator, is the fact that particularly in Los Angeles County, our population is so diverse, and it isn't sufficient for us, we've learned, to establish mental health centers and say to people, well, here, come to our mental health centers and receive the help that you need. We need to make sure that populations that have traditionally not accessed mental health services have the kind of outreach and education that's required in order to ensure that their behavioral health needs are met. So we're increasing the size and the capacity of our workforce, experimenting with models like Promotoris models. Actually, right here at USC, we have a collaboration that we're funding with the University of Southern California to develop a cadre of peers, people and family members in recovery who have a sensitive knowledge of what it takes for people with mental health and behavioral health issues to be able to access mental health services. And so we're training non-traditional professionals in order to expand our workforce. So we're increasing our contractors, our contract network, we're increasing the kinds of providers that we bring into our network so that we're sure that we can meet the expanded need in 2014. We're also looking at new clinical models for service delivery. In 2014, in addition to everything that we've already talked about, we know that we'll be evaluated based on our outcomes. Not only how efficient and how productive we are, but whether or not we can show that the work that we're doing produces outcomes and is effective, is helpful in the lives of the clients that we see. So we're doing a couple of things. First of all, we've entered into some agreements with entities, universities, and other entities on a national level that have expertise in delivery of integrated care meaning mental health and behavioral health care in primary care settings, and also vice versa, and I'll talk about that in a minute. And we're training our workforce, we are retraining our workforce to ensure that everybody is capable and knowledgeable about those evidence-based practices that will ensure that we fulfill our obligation to the Affordable Care Act, that we can produce the outcomes by making sure that our workforce is trained in those proven strategies that are successful in treating people with mental illness. And second, we're also investing in a data collection system. In addition to our electronic health record system, we're building in strategies for collecting outcome information so that we can actually demonstrate that we're effective. And we've actually made quite a bit of headway in that arena, largely because of the Mental Health Services Act and some of the innovations that we've been able to promote in Los Angeles since 2004 when that act was passed. When I say that we're experimenting with different models of service delivery, they're structural models integrating behavioral health in primary care settings and vice versa. We also have a number of experiments in which we're bringing medical practitioners into our mental health centers so that people that won't or have traditionally had difficulty accessing medical services because of their behavioral health needs, they can get their medical services often in settings where they're more comfortable, settings that they may prefer, so that medical personnel are being integrated into our behavioral health settings. And then under the Mental Health Services Act, we've had the great good fortune to be able to implement 3 innovative strategies through our innovations plan, looking at different models for integrating behavioral health and primary care, particularly for people with significant and unique needs. And so one of those models is the Integrated Mobile Health Team, and that involves doing integrated care for people that are homeless. We bring together medical personnel, behavioral health personnel, mental health, and substance abuse personnel on one team. And on that team, we also, those clinicians are also joined by housing providers, so that we bring together the whole cadre of professionals who need to have some say in changing the life of homeless individuals with primary care and behavioral health issues who are on the streets. That program began about 6 months ago, and already we're seeing tremendous success. Our second innovative approach is something that we're calling the integrated clinic model, where we're experimenting with integrated primary care, mental health, substance abuse, in some cases led by primary care providers. In some cases, it's the behavioral health providers that are the leaders of those teams. And the third model is something that I think you'll be really interested in, and that's our integrated services model, where we're bringing together those same groups of professionals and focusing on outreach to underrepresented communities. And those integrated service models are targeting and focused on the African American community in Los Angeles, the Latino community, the Asian Pacific Islander community, the Middle Eastern community, and the Native American Indian community. And we're looking at the integration of culturally appropriate approaches to the integration of primary care and behavioral health. So for us, 2014 is around the corner, and we're just gearing up and moving forward with system expansion, system redesign, and increasing the access and building the workforce that will carry us to 2014 and beyond.
So that's a really nice. So as we begin to see some of the innovations, I like to think that we're really at an inflection point in terms of healthcare. And the Affordable Care Act really provides impetus for innovation. So it's nice to hear that we are seeing some experiments, some innovations taking place, because one of the components, and Herb, you may have mentioned this, but one of the components is to find ways structurally for integrating across the continuum of care. I don't know if you want to talk a little bit more about that.
Sure, and I think you also, I think all have raised a very important point with health disparities, because there is a very, very significant part of the Affordable Care Act that's focused on a public health and prevention fund and an effort that there is a national strategy to reduce racial and ethnic health disparities. And as a part of that, the HHS plan is really keying off of all of the provisions that are in the Affordable Care Act. So you mentioned the sort of mental and behavioral health side of that. There are experiments doing exactly what now LA County is doing, because we learned from that, where both primary care services and mental health services are provided at the same point, but actually the handoff is from the behavioral health side to the primary care side, not the reverse, because that's where we've had a system and we've seen some of those issues and some of those parts of that. The accountable care organizations that I mentioned, I think that's a very big one, because it's in Medicare. It is another, if you will, delivery system or way to provide integrated, coordinated care to Medicare beneficiaries who, unlike California and the rest of the country, don't know very sophisticated managed care. And so it is not a closed system, but is a preponderance of services that you would receive. And everyone from a federally qualified health center or rural health center could be the governing body. Physicians have to be the sort of majority on the board. It could be a network of individual physicians, or as we've seen in many awards in Southern California, it's been health and hospital systems in coordination with physicians, nurses, home health agencies, assisted living facilities, hospices, all of that sort of thing. Payment side has been the same thing. If you want to look at getting paid for bundling of services as opposed to individual payments going out in a system and it being somewhat scattershot. So all sorts of initiatives, but with that really, as you've said, that overall arching is this significant effort in all the communities that were mentioned and more to reduce racial and ethnic health disparities.
Thank you. That's helpful. One of the things that has me scratching my head a little bit, since we have a professor here of medicine from Keck University, is what are the implications for research and teaching that emerge out of this? And I suspect Robin has the same thing for you as well. So maybe since we are in kind of an educational institution, how is that going to impact on what you're doing?
Thank you for bringing that up. That was a point that I had meant to include in my original remarks. Los Angeles County is the largest producer of doctors in the country. Currently, on LA County USC alone, I have 900 residents in training. Every year, we graduate several hundred residents who go out into the community, many of them who come to our training programs with the intent of providing services to underserved areas. So graduate medical education is very key to the Affordable Care Act. Last year, the Affordable Care Act called for redistribution of what we call CAPS, which is the federal support for graduate medical education. And those CAPS, in other words, that weren't being used throughout the country, were redistributed to areas that are underserved for the purposes of training primary care physicians in areas where there is insufficient supply. Having said that, there's still not enough. There are not enough primary care providers, and also the AAMC, which is the American Association of Medical Colleges, projects shortages in almost every specialty in medicine. So one of the things that we really need to look at is if we're sufficiently training enough doctors to meet the expected demand. So we are in collaboration with USC. We have been since the 1858, I think, that LA County USC has affiliated, or the county was affiliated with USC, and also the county is also affiliated with UCLA at the other hospitals at Harbor UCLA Medical Center and all of you UCLA Medical Center. And part of our mission is collaboration for research. Currently, our center provides our patients, about 80% of our patients, for example, in cancer, have been offered or are enrolled in trials, clinical trials. This is an opportunity that is not available to most underserved people. That usually it's only if you go to a high-end insured population that have access to unique and innovative therapies. And pretty much our patients have access to the clinical trials that their counterparts at the private university hospital across the street have the same access. So we are very active in research and participate as a partner to provide those opportunities for our patients. And many of the breakthroughs in clinical translational research occur through the research in the population that actually come from our patients in collaboration with the university. So that is one of our missions, and I see that the opportunity going forward with the Affordable Care Act is further innovation in implementation science. And the focus, earlier Dr. Bostic mentioned that one of the areas is that health policy is very interesting, and a lot of academics will develop interesting theories and opportunities, but really when it gets down to it is how do we implement it so that it reaches the actual people that need the service. And so implementation science is an area of interest and focus for the Department of Health Service.
So I want to echo what Stephanie has said. The Department of Mental Health is involved with both UCLA and USC in a variety of opportunities related to translation, what's described as translational research. We also have some agreements with other universities a little bit farther away than the LA area, but to look at both on the level of client outcomes and even more on the level of system outcomes. How is our system performing? What are we learning about the system level changes that we're making that can be informed by research done in the university and translated into the public sector and vice versa. And so we've been blessed in Los Angeles County to have two great training institutions and teaching institutions, research institutions, that can help us answer those large questions that we need to ask going forward. I will say that in the past, the mission of the county has not been research. We've been focused because of the scarcity of service delivery dollars more on a public service mission. And so this is really a unique opportunity for us to partner with universities to answer some of those big questions that actually, at least in my department, we don't have the capacity to research and to address on our own. So it's a really good partnership. We talked a little bit about teaching and training. We're very much involved in supporting the training institutions in Los Angeles, again, largely through Mental Health Services Act funding. We work to support training of social workers and psychologists and physicians, psychiatrists, as well as paraprofessionals, and certainly will continue. Many of those individuals who go through training programs are also placed in our programs to get that real life, on the ground opportunity that will be so helpful as we move forward. So.
And speaking of on the ground, life, affirming internships. We were just talking, I want to give my information out because for those of you that are students or that are working with other students, our main office, if you will, for the region is San Francisco. I do live here in LA County, just so you know. I work in San Francisco, but I am in LA County. And but in all sincerity, they're not paid internships in most of the department, although there are things, but it really is for anyone that's interested in really the practical implementation of the Affordable Care Act from the federal level. That's what my office is doing, and that's what we will be doing in the spring as well as all of next year with going live, on some parts of this October of next year. So I will give out my email and my cell phone for a number of different reasons, but just for the students in the room that are interested in possible internships, it's Herb, H-E-R-B, .Schultz, S-C-H-U-L-T-Z. That's Herb, H-E-R-B, .Schultz, S-C-H-U-L-T-Z. Cell and text is 415-265-7049, 415-265-7049. If your interest is another government agency too, I can help network you, and happy to.
I'm going to open up for questions in one moment, but I just wanted to ask Ed, if you comment on this idea of we need more health manpower or human capital. And if we think about what's happening with our state and community college systems, it doesn't look like there's a rosy sun on the horizon there. So how is that playing up in Sacramento, thinking about the implementation of this and the health resources we need to make it happen? And then we'll open it up.
Thank you very much. Yes, definitely there is a capacity issue and more importantly a workforce issue, and yes, I agree. There aren't very many resources, especially in the state of California, to be opening more medical schools or unfortunately growing more universities. Just for example, UC Riverside has been trying to open a medical school for years and it's very difficult. But in order to address this, there's several things that we should do. And obviously I'm the internal optimist and hoping the economy will and continue to pick up and we'll get back to much better days. But several things we need to do. Number one, obviously at a very basic level, is to encourage more individuals to go into the sciences, go into the health professions, but more importantly, to make sure we draw down as many federal dollars as we can to have residency programs in the areas where there's the need the most. Because when you have a residency program, it's that provider that has a tendency to stay in those locations. That's one thing we need to do. Obviously, looking at increasing reimbursement rates, because reimbursement rates, especially at the Medicaid or Medi-Cal level, drives network adequacy. And as you know, more and more physicians, even though I know there's going to be a shortage from specialists to primary care providers, have a tendency to go into specialty care because of the reimbursement rate and, of course, the high debt that individuals have coming out of school. That being said, in a perfect world, if let's say we were to increase the manpower and individuals going to medical schools immediately, you're still not going to see that workforce available for 5, 10, 15 years. And we have an immediate need right now, plus the emerging baby boomers. So from the fact that we have to follow that course, but we also have to look at other mechanisms of getting a workforce. And currently the state of California does have that ability. And what we've done is we've looked at, we've had committee hearings on workforce for the last 2 years while I was in the Senate, the last 4 years while I was in the Assembly. And if you look at every single provider that is licensed under the Department of Consumer Affairs, we have to look at utilizing that current workforce in those licensure categories at the highest level that they're capable of seeing and utilizing. Keeping in mind that number one, patient safety is the most important, and that we can increase their scope of practice to the fullest of their extent. I'll give you some examples of some provider groups that we need to look at immediately. Nurse practitioners, physician assistants, pharmacists, podiatrists, dentists, optometrists, psychologists to be able to fill that void for mental health. As you know, in the essential health benefits, mental health is one of the 10 essential health benefits. So we're gonna have a huge need for mental health providers. So what we have to do is make sure, and there is the capacity, and I always use this as an example. If you look at pharmacists, in my opinion, are the most underutilized and overeducated health provider that we have currently, and there's an immediate workforce availability of over 40,000 licensed pharmacists in the state of California. Pharmacists are now graduating. You have a wonderful school here at USC with a PharmD. They're doing their undergrad, they're doing their 4 years of postgraduate work, and now they're doing residency programs, and they're doing a lot of patient interaction. So imagine a pharmacist as a primary pharmacy provider that does everything from increased, vaccinations to looking at diabetes testing, to high blood pressure, to BMI, so that they have the ability to interact with the patient, and then if they pick up or determine it's necessary, then they can refer into the integrated model or the medical home model. So what we have to do immediately is to look at the current workforce and utilize them the most efficient possible way we can. And I think that's how we're going to address it, as well as concurrently working along to make sure we get more individuals into primary care.
Okay, thank you very much. Herb wanted to make one comment, but I want to open it up, so if you want to just make that one.
Yeah, just for all of you to know, because I want to compliment the Senator, we've worked a lot on the workforce issue together and provided. There are hundreds of millions of dollars coming out through the ACA on everything from not just the physicians, but recognizing those issues of how quickly they need to happen, to PAs, to nurse practitioners, to nurse-managed clinics, to school-based health centers, and several other categories that are there. We've tripled the size of the National Health Service Corps within the 3 years from the stimulus to this. So this is a real live issue, and there are real live opportunities for students, even people coming out of high school into college, that could start thinking about those things.
Okay, I don't see any roaming microphones, so if you got some questions, speak loud. Yes.
My name is Dr. Nguyen. I bought the traffic to be from Orange County. I have a comment and I have two questions for your panelists. The comment that we have a workforce catastrophe happening. I'm glad you say pharmacists can do primary care if they can. One of the things that wasn't mentioned is there's this undercult culture of in our medical schools that is discouraging really smart students from pursuing primary care, such that less than 10% pursue primary care. I'm a class of 1995. I survived the LA riots. I'm a Trojan, and I started a statewide mentorship program to get kids of color into primary care, into pathways of leadership at the CMA. I really would like to speak to you, Dr. Hall and Dr. K, regarding that. It's called Exchange Learning, Excel, and it's getting funding from the CMA Foundation, and we're building it. My question to you about workforce diversity is, I also represent API communities and Latino communities. I'm trilingual and tricultural in all three. And what can we do to build the bridge between your LA County huge system that's getting great dollars and getting Herb Schultz's 120%, 24/7 attention to Orange County, where there's a lot of API folks like me who are Vietnamese American who suffer from PTSD and all kinds of complicated mental health issues. I have a fourth-year medical student who's from Afghanistan, and he's doing landmark research on the PTSD from his Afghan community. I mean, I'm glad to see people are starting to see that healthcare and behavioral health are intermeshed, that we are psychosocial, spiritual entities and not just disease entities. And so the collaboration in LA County, of course, is innovative, but how can I help you? I'm in the trench. I'm in a little clinic. I'm in primary care, solo small practice, and I spend a lot of time on my own time doing advocacy at the state level. So how can I be of service, and how can we expand such grassroots sort of programs with you?
I think you make a very good point, and I'd like to go back to what the senator mentioned. The first thing is, in order to incentivize practitioners to go into primary care, there has to be a realignment of reimbursement, because primary care continues to be one of the lowest paid specialties. And when a student currently graduates from medical school, on average they have about $150,000 in student debt. That will take a lifetime for them to pay off at the current economy if they do not get reimbursed. So it's a matter of a math equation that in order to eliminate or improve that disparity, we have to somehow figure that part out, because otherwise students will continue to pursue high paying specialties. And those tend to be procedural related specialties, and the change in how the government reimburses will also help. So for example, bundling payments and stop paying for a particular procedure versus paying for the care of a patient in a managed care model, I think will have a significant effect and will allow students the opportunity to move into primary care. The next area that I would encourage you, and I would, is to participate in the education of our not only our residents. We also at the University of Southern California have a PA program, a primary care PA program, and one of their biggest challenges is to recruit training sites. People like you who are willing to allow a student to come and participate in the training. So I'd like to hook you up with Dr. Lohenry, who runs our PA program, and having a site where our students can go and learn and become part of the community, I think is really one of the most powerful ways to address the disparity that you're referring to. And so, again, not only do our medical students need that experience, but so do our PA and primary care programs. Now, while I am not associated with the state system, schools like Cal State LA that runs a primary care nursing program, I've been in contact and worked closely with the dean of the nurse practitioner program there. They also need training sites. So any of you who are members of clinics out there that wish to participate in this educational process, it's easy. All it takes is a commitment to participate. So I hope I answered your question.
So how can we cross that orange curtain and build that bridge?
And early intervention programs, and those programs have rolled out in all counties in California, including Orange County. I would recommend, the other hallmark of MHSA, let me take a step back, is that it is by statute a stakeholder-driven process. Every person in California has an equal voice in how those programs roll out. In Los Angeles County, the integration of primary care and behavioral health is embedded, integral to two of our plans, prevention and early intervention and the innovations plan. but in most counties, it's there in some fashion. And each year, we take another look at the plan. Next year, we'll be gearing up for the development of a new 3-year plan, and I think all counties have got to develop those plans with an eye toward the ACA. So this is a wonderful opportunity, if you're not already involved in that stakeholder planning process, to bring that voice into the mental health service delivery planning MHSA process. And if you go on the county's website, if you go on our website, you'll see about the Los Angeles County MHSA programs, and I'm certain that the Orange County website has the same information. And if not, you can contact me and I'll make sure that you get the link.
Yes, way in the back.
Good afternoon. I'm Jack Barber, and I'm a psychiatrist and director of one of the legal entities that Rob acknowledged just a moment ago, which is a behavioral health entity. I'm curious with the ACA, as we talk about the uninsured and those that are represent a certain level of the poverty line, what happens to the undocumented? And I'm aware of some of the issues of ACA and undocumented, so I thought it needed to be actually spoken to here, and how that might be, and how a health insurance exchange might interact with that population of underrepresented people.
I can tell you that the undocumented, what Congress did is it said most U.S. citizens, because there are some small exemptions, and documented individuals. There's an $11 billion expansion of the federally qualified community health center system. We just did an event, for example, at the THE clinic with 12 FQHCs from LA County that won New Access Point Grant Awards. And the clinic expansions, as is the case with hospitals, is having to take all people regardless of their ability to pay or their status or not. And so that continues as a part of that. But the ACA did not take into account the undocumented being in the system.
Professor Frades?
Hi, I'm Jan Frades. I teach at Cal State and I'm a proud Trojan alum. I want to ask about administrative simplification, especially as it has to do with Medi-Cal. There's a section in the Affordable Care Act that deals with it, but it's pretty vague. So I'd like to know about some details, because I think that's a real key to opening up more participation in Medicaid and Medi-Cal. I mean, what's the deal with Medi-Cal? More paperwork, less money. If we can change that paradigm and capitalize on the temporary incentive to participate in Medicaid by paying Medicaid primary care practitioners the same as Medicare that's in the Act for a time-limited period, it's a great window of opportunity, and I'd like to hear what people are doing about it.
The senator may want to address the state side of it. I can tell you that we have put out some significant sets of regulation. We're estimating that in the administrative simplification, and this is for hospitals, for physicians and other providers, exactly for that reason, health plans will be about a $12 billion savings over the 10 years. And so outside of here, I'm happy to take you through those. There are some things that have been finalized and are just beginning, but there are others, I think, a couple of weeks ago where we put out and said, here's the draft proposal that we want people to react to, because you're exactly right. I mean, I worked for the last two governors, not Governor Brown, Governor Schwarzenegger, and Governor Davis, and working with the senator when he was in the Assembly first and now that, and there are significant issues that need to be addressed on the Medi-Cal side. And so for this effort, the ACA provisions, we are significantly trying to fill in the box, if you will, and any amount of input we can get from the provider communities, the health plan communities, consumers that are hassled by it all as a part of that, we want to take.
Yes, I'd like to just kind of answer on the state's perspective. As you know, if you look at the system we have now, there's already Medicaid provider network inadequacies, and very few providers are taking it, obviously, because of the reimbursement rate. And to address a lot of the questions out here, and some of the comments made. So the good news, at least temporary, once 2014 comes, that Medicaid reimbursement will be 100% of Medicare at least for 2 years.
Yeah, 13 starting this January.
Is January, to at least to encourage more participation. So that's a big chunk, and hopefully after that it will continue, assuming the economy picks up. But don't hold your breath, because you know that the state of California, their general fund, it just always seems that healthcare always seems to get the last bite at the apple when it comes to resources. But as you know, the state of California has moved away from fee-for-service as we know it, so it's going to be all an integrated managed care model. All the duals, the SPDs, all of those are changing dramatically. So as we move forward, as I mentioned earlier in my opening remarks, we have to learn to be more efficient, see more patients at a lower cost, but be more effective as well. But hopefully the 100% of reimbursement of Medicare will help kickstart and get more providers into that, because as you know, the eligibility for Medicaid is going to increase very shortly to close to 133 of Medicaid of the poverty level, and you're going to see huge increases, as was mentioned here in the county, up to 3-4 million new enrollees going in, and we're going to need to be able to service those patients.
And the other piece is the focus that the ACA has on fraud and abuse, because it enters into sort of all of this. And over the last 2.5 years since the law passed, there's been $11+ billion, if you will, that has been found through more boots on the ground. We couldn't talk to the FBI or DOJ before, and so now as a part of that, 5.7 billion of that went back into the Medicare program. So last year was the first ever for this year, 2012, first ever drop in the premiums that seniors and people with disabilities have to pay. And we're looking at flat rates for the Medicare Advantage HMO program, flat rates for the drug program. Much of that is because of the anti-fraud activities as a part of sorting out the administrative stuff.
Thank you much. I want to turn it back to Raphael to bring it together, but I want to thank my panelists for their ideas and insights, Dr. Robin Kay, Senator and Dr. Ed Hernandez, and Dr. Stephanie Hall and Herb Schultz. So I'll take it over to you.
Let's give a hand for the panel. They were fantastic. And also a thank you to Dr. Bob Myrtle for the moderation. And Herb, we'll call you an honorary doctor for the day.
Oh, thank you.
So you're one of us.
Oh, and this honorary doctor, on the table, you actually have our general PowerPoint about the law, and I just wanted to bring that to folks' attention because you've got the, not only that, it's got all my contact information on it. We have a listserv, and I just wanted to put that out there for people. We also say how the law is making a difference in California. So if you want to see the main provisions of the law and say, well, how many kids in California, 19 to 25, are getting insurance, it's there.
And Dr. Hernandez, Senator Hernandez, we'll note the UCLA affiliations. I'm going to cut that out of the video. Just But thank you very much. Thanks to all of you. You're incredibly busy. I really appreciate the time that you've taken for this. So I wanted to thank all of you as well. These events are only as successful as the people who come and take information from them. A lot of food for thought here, a lot about ways that we can improve the delivery of services and help strengthen our system to make sure that health care is provided in a safe and cost-effective and affordable way to improve public health, because ultimately, this is part of the discussion that doesn't happen. If people are uninsured and they wind up being not healthy or less healthy, we pay for that anyway, right? And usually in a more expensive way. And so it is imperative that we all find a solution because we're all in this. So, so thank you all again, and keep an eye out for the next in this series of discussions. And if you have suggestions about possible topics, be sure to get in touch with us. I want to thank Paul and Veronica. Please stand up again. She spearheaded this, a tremendous effort here. And please do continue to keep an eye out for our events. The Bedrosian Center will have a series of them through the course of the year. And panelists, thank you again. Have a great afternoon, everyone.
Thank you.